Hello, I'm Ravina Tan of Creative Educational Concepts. I would like to welcome you to today's educational activity entitled Desmoid Tumors in Focus, Early Recognition, Evolving Therapies, and Nursing-Led Care Strategies. Today's program is supported by an independent educational grant from SpringWorks Therapeutics. A note that today's activity will include discussions of products or devices that are not currently labeled for use by the United States FDA. We'll try to point that out as we go. My name is Ravina Tan. I am an associate professor of sarcoma medical oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. And I'm joined today by my good friend, Nicole Petrolkowski, who is a nurse practitioner at the Siteman Cancer Center, Washington University in St. Louis, Missouri. We'll also be hearing today from Christina Kostia, who is a patient and advocate for patients with desmoid tumors and has experiences to share. These are our disclosures. Our learning objectives for today are to identify key clinical features and diagnostic challenges of desmoid tumors to improve early recognition and appropriate triage. Second, to evaluate patient eligibility, potential benefits, and safety considerations for novel targeted therapies to support evidence-based treatment recommendations and individualized patient care in adults with desmoid tumors. And lastly, we hope to explore implementation of evidence-based strategies in clinical practice to monitor and manage adverse events associated with systemic therapies for desmoid tumors to improve patient safety and adherence. So our first segment is going to be entitled Diagnostic Challenges, Unmasking the Tumor. So first, to start a little bit by defining the disease, desmoid tumors are rare, locally invasive, soft tissue neoplasms. They are not traditionally considered cancers, but they are locally aggressive. They can cause symptoms like pain, loss of function, occasionally cosmetic impacts, but they are not expected to spread to other parts of the body. They're usually slow growing, although that's not always true, and most often present as a painless or slightly painful mass in the extremities, the superficial trunk wall, and occasionally can occur, or with some frequency can occur intra-abdominally as well. It's important to recognize that most masses that present this way in people are benign and are not desmoid tumors, and patients are often told that they have benign conditions like lipomas or other causes of soft tissue swelling, and something like a desmoid tumor tends to be lower on the list for people who are seeing these patients. And because of that, we see patients often feel like some of their symptoms are dismissed. That being said, desmoid tumors can cause substantial morbidity due to their aggressive local behavior and tendency to recur. People can lose a lot of function, and historically, the treatments that we've had to offer can cause their own downstream consequences. These are rare tumors, somewhere between 700 to 1,500 new cases a year. But those are new cases. It's important to recognize the prevalence. The number of people living with the disease is much higher because desmoid patients often live with a desmoid tumor, in many cases for the rest of their lives. Most of these patients don't have an underlying genetic cause for the tumor. They have a beta-catenin mutation in a specific gene in the tumor, but these are not passed down from parents to their children by and large. The exception is the 5 to 10% of patients with desmoid tumors that have familial adenomatous polyposis syndrome, also called FAP, which most often presents with colon cancer in patients by the time they're 18 years old. So these are patients that actually have removal of their colon typically around the time that they become adults. They are also at increased risk for desmoid tumors. Most patients with both sporadic and the FAP-associated desmoid tumors are young. They appear most often in patients between 20 and 45 years of age, and there is a female to male predominance with more women getting the disease.
I'm going to discuss the quality of life burden of desmoid tumors before we dive into our first patient video. Some of the most commonly reported symptoms that we hear from patients include disfigurement or altered appearance, depending on the location of the desmoid tumor, nerve pain, which is also dependent on the location of the desmoid, decreased range of motion, along with fatigue and nausea. Unfortunately, these symptoms often can cause fear in patients of the underlying condition before diagnosis. Difficulty sleeping, depending on that location and position of the desmoid, concern about lack of knowledge among the healthcare team, anxiety, and ongoing medical uncertainty. Here we have Christina. She's going to tell a little bit more about her story on the next slide with a video. But her symptoms began in 2017 at the age of 28. Her tumor was initially thought to be a lipoma. So she was seen by multiple healthcare providers, including physical therapist and an orthopedic surgeon. Ultimately, at that time, she had a surgery to remove what was the suspected lipoma. When she continued reporting pain, she was unfortunately dismissed and told that it was normal post-surgical swelling, despite her persistent symptoms. In 2018, she underwent a core needle biopsy that it confirmed it had been a desmoid tumor all along.
My pain has gotten better, but I have been living with chronic pain now for a good deal of time. I was extremely physically active when I was diagnosed. Or before I was diagnosed, one of the reasons I sought care was I was teaching and practicing yoga, and my handstands weren't, I couldn't hold my handstands as long, which is such a funny start to the story because I don't know if I would have noticed it as early otherwise, but there I was, standing on my hands. I can't do weight bearing. So I can't be, for example, on my hands and knees, a downward dog pose in yoga. And that was a huge part of my life prior to this. So my physical activity has really changed. I also I am tired. I'm fatigued, not only from the pain, but from treatment. I would say, just as importantly, the mental health challenges are quite large. It's taken me a long time to come to terms with the fact that this is a chronic condition for me that needs ongoing treatment. So many people that I had heard previously had kind of this health issue that they were able to solve and then move on. Whereas with the desmoid tumor, for me, it's living with as compared to, moving on. Getting others to understand this diagnosis is really hard, family and friends. I'm so grateful that I have the supportive, loving friends that I do. But every desmoid tumor patient I know has been told some version of, well, you don't look sick, or, at least it's not real cancer, things like that, which really diminish the experience of living with a chronic illness.
We thank Christina for sharing her perspective with us. Here, we'll look at a case study that we're going to go through during the course of this presentation. We have a 35-year-old female who presents with mild discomfort in the lower right abdomen. She is unsure if the pain increases with menstruation. She reports no constitutional symptoms such as weight loss, fever, or night sweats, and no gastrointestinal or urinary complaints. Her skin is intact without erythema, ulceration, or lymphadenopathy. She is a non-smoker and low alcohol user. She has 2 children and uses oral contraceptives. She had a C-section with her second child, but reports no history of FAP or personal or family history of malignancy. Some of our differentials could include endometriosis, a lipoma, a sarcoma, a scar tissue, or other benign causes of abdominal pain. Often desmoid tumors can be misdiagnosed initially. This can be due to limited experience with diagnosing desmoid tumors in the community setting. Patients report their symptoms, but unfortunately they are not taken seriously. Misdiagnosis has been reported as high as 30 to 40%, and it often causes emotional distress for patients. This can further lead to delays in treatment or mistreatment, which can lead to additional problems down the road. Desmoid tumors are far more rare than other types of soft tissue tumors. As previously mentioned, their incidence is 2 to 6 per million per adults in years. Oncologists, general practitioners, pathologists, nurses, and other healthcare team members will see few, if any, patients with desmoid tumors in their practice. Desmoid tumor symptoms, as we've discussed, can often overlap with other conditions. They can be mistaken for slow-growing, painless masses that are frequently mistaken for lipomas, sarcomas, or other benign cancers. Some imaging studies may not distinguish desmoid tumors from muscle or other soft tissues, including scar tissue. They may be mistaken for endometriosis in the abdominal wall for women. Tumor cells appear similar to myofibroblast as seen during the proliferative stage of wound healing. Many pathologists are not familiar with desmoid tumor histopathology, so a pathologist with experience in soft tissue tumors is recommended. As discussed before, the beta-catenin and APC mutations are both mutually exclusive to the desmoid tumor, with beta-catenin occurring in 90 to 95% of desmoids and the APC mutation occurring in 5 to 10%. It's an unclear epidemiology and unknown causative factors that cause desmoid tumors. Up to 25% of cases are associated with trauma, such as surgery. And as our case presentation mentioned, she had a C-section prior as well. Estrogen and pregnancy are especially a higher rate in women, particularly those of childbearing age. The course of desmoid tumors is unpredictable. It can include spontaneous regression, stable disease, and disease progression can all occur, and there is a high risk of recurrence. Here, we'll hear from Christine on some of her challenges with being diagnosed.
I had the surgery where I was told that they didn't find anything in my chest, which was strange because in addition to the pain and the symptoms presented that way, I looked like I had swelling on my collarbone, which is where my tumor is. Quite frankly, I think I was treated as a hysterical woman, which is not uncommon in the medical field, the greater society at large. I was told that, I was a little upset post-surgery when I was told they didn't find anything. What was not disclosed to me is that they removed a 3-centimeter mass. That was on the surgical report, but I was never given a copy of that report. And so the conclusion I could draw, they did a pathology of that mass, and they said it was lipoma tissue. When I kept going back saying, I'm in pain, something's not right, I was told, well, this is swelling. This is standard for surgery. It was a more invasive surgery than we thought. So when I was reporting problems, I was rather written off, and I was told again to go to a physical therapist, which I had already been to the physical therapist, I think 2 of them at the time. When I did end up at university level healthcare, and they took their own core needle biopsy, they compared it to the same pathology slide, and it was the same. It had been a desmoid tumor all along. So in my mind, there was, I didn't feel listened to. I didn't feel heard.
Looking at the nursing role in desmoid tumor diagnosis, so oncology nurses play a critical role in patient support during all treatments, serving as the backbone for comprehensive care for our patients. Nurses can help build relationships with patients, allowing patients to feel comfortable discussing these sensitive matters. So patient education, care coordination, and emotional support for our desmoid tumor patients is crucial.
For the next portion of our discussion, we'll be talking about navigating treatment and looking at targeted therapies in action and trying to put those in context of the larger treatment landscape for patients with desmoid tumors. So going back to our case, Tina, for her, ultrasound reveals a firm hypoechoic mass within the abdominal wall musculature. An MRI of the abdomen reveals a 5 by 4.2 by 3.8 centimeter mass within the right rectus sheath, which is isointense, so the same density as surrounding muscle. It's infiltrating but not invading adjacent bowel or organs. A core needle biopsy is obtained. Pathological assessment visualizes spindle-shaped cells in collagenous stroma, beta-catenin nuclear positivity, no features of high-grade sarcoma. Based on this, she had diagnosed with a desmoid tumor in the abdominal wall, with the sarcoma ruled out based on the histopathological findings. I want to clarify, it is abutting but not infiltrating the adjacent bowel. So these are indications for deferral of treatment. This is when we would think about not treating a patient with desmoid tumors. And I think this is an important point. So historically, when we saw a desmoid tumor, physicians and providers would be eager to immediately treat that tumor, thinking this was going to behave like a cancer. And we've learned that that's not necessarily the case. And so many patients are just watched. Specifically, if the tumor is asymptomatic or not threatening critical structures, very often on serial imaging, these tumors are stable or even will regress spontaneously. And so even a growing tumor can be watched for a period of time. And something like a third of the time, we will see that if you watch a desmoid tumor long enough, it may stabilize and shrink on its own, even if it's initially growing. And so what we're always trying to get at is whether the risks and adverse events related to therapy are likely to outweigh the potential benefits. In other words, if the desmoid tumor is not bothering someone, then we have to look at the side effect profile of any treatment that we'd be offering in order to assess whether treatment is appropriate. Conversely, patients that we would treat, if the patient has a tumor that's progressively enlarging scan after scan, especially if we're concerned it's going to impinge on structures or become symptomatic, that would be an indication for treatment. It does not always have to be, but it often is. And candidly, patients are uncomfortable watching a tumor grow scan after scan. And so sometimes we treat recognizing that that's probably the best way to manage the impact that that finding is having. Certainly, if a patient develops symptoms such as pain, limited mobility, obstruction in the cases of intra-abdominal tumors, or other organ compromise, that would be a reason to treat. It's also a reason to treat if you think that that is about to happen. You don't have to wait for symptoms to happen. You can also treat if you think there's some sort of pending anatomical problem. And certainly for these patients that have tumors that are growing very rapidly or are very infiltrative in a way that makes us uncomfortable, that may be a reason to treat, even if the patient doesn't currently have symptoms or pending compromise. For Tina Z, observation is recommended because the mass is not threatening vital structures. It's in her abdominal wall, and her symptoms are relatively mild. She's followed at intervals at 3 and 6, 9 months, which show that the tumor continues to grow, and she starts to have more abdominal pain. So now we're actually having pain that we attribute to the presence of this desmoid tumor in her abdominal wall. What would you recommend for her at this point? Okay, so 50% of people recommend surgery, 25% recommend systemic therapy, 21% recommend cryoablation, and 4% for radiation therapy. So let's talk a little bit about some of these treatment options. Radiation, the least popular option of the menu given. This is a standard therapy for desmoid tumors. There's a long history of using radiation to treat these, and it can be quite effective. We see 70 to 80% of patients have local control and experiences done at our institution and others. It's pretty clear that younger patients do less well. Their tumors seem to be less well controlled by radiation, and we define that as patients less than 30, although that's a continuum. And we also worry about the long-term side effects of radiation in patients who are young. We do see some evidence, we do see some incidents of secondary malignancies, new cancers in patients that have had prior radiation. And when someone has a long life to live, we worry about that down the road. And so this is in the guidelines as an option for patients with desmoid tumors. The response time is typically months. The tumor doesn't melt on radiation. They receive a course of radiation, and then the tumor will often slowly regress over a period of months. Similarly, pain relief tends to take months. There can be some stiffening or fibrosis of the tissue around the site that is radiated, which can have its own functional consequences. And like I said, there's that low risk of radiation-associated malignancies. And so you can see here on the right side, this is a figure that shows that patients with radiation do better when they are older. So this line up top here is the 82% of patients who had long-term control and were older than 30 versus 57% of patients who were younger than 30 receiving radiation for their desmoid tumors. And that's with 10 years of follow-up. Cryoablation is an emerging therapy for desmoid tumors, and I think one that many of us are using more frequently. The nice thing with cryoablation is it's minimally invasive. You're not doing a big surgery. And it's a one and done treatment in contrast to systemic therapy, and it doesn't have the secondary malignancy risk related to radiation. The goal is to get rid of the tumor entirely, to either treat it completely so that it never grows again. Sometimes it can be used to treat a portion of the tumor, although we do that less frequently. And you can do multiple procedures serially. Unlike radiation, where typically you get one try at it, cryoablation can be repeated. Again, it's important to set patient expectations. The tumor shrinks over months after the tumor is treated. Pain relief also takes time. It's not instantaneous after the procedure. And you can see injury to neighboring sites. So if a tumor is too close to the skin, you can see frostbite, which can be very severe. Pain can increase in the short term. You can have nerve or blood vessel injury or other complications related to damaged structures in the vicinity of the tumor. That being said, for patients that have tumors that are anatomically amenable, this is often a very popular option. I found that patients really like it when they're appropriately selected. Looking at a sort of qualitative comparison of radiation versus cryo, radiation has been around for a lot longer, and so there's many studies that support its use. Outcomes seem to be similar. Cryoablation has often been used to partially treat tumors, and when that happens, you do see that there's an increased risk of recurrence, perhaps not surprisingly. We like radiation therapy more for older patients. The other thing is it's very difficult to do radiation inside the abdomen. So if the patient has a desmoid tumor that's got bowel draped around it, it's very difficult to safely give a radiation dose. That's also true for cryoablation. We typically don't do cryoablation for desmoid tumors that are inside the abdomen. Abdominal wall can be done, but if it's inside the abdomen, we worry too much about injuring bowel. And then for radiation therapy, the main limiting problem is bowel. You can actually safely occasionally radiate nerves and so forth, whereas with cryoablation, you don't want to risk injury to those structures because that can often be irreversible. There's no randomized trial or head-to-head comparison that says one is better than the other. So these are both kind of options on the menu for patients who are receiving desmoid tumor treatment. So prior to 2023, with the approval of nirogacestat, this was the menu of systemic agents that were typically used to treat desmoid tumors. So medicines that we use either by mouth or by IV to treat the tumor. Anti-inflammatory agents like Sulindac and indomethacin, as well as anti-estrogenic agents like tamoxifen and raloxifene, have really fallen out of favor. There's limited evidence to support their use. And so I would say that in most guidelines published by experts, and certainly in our clinical practice, we tend not to use these medications anymore. I mention that because we do still see patients come in on them, but I think the evidence to support their efficacy is really limited at this point, and we have better choices. These remaining agents are all treatments that we do still see for desmoids with varying levels of evidence. In some cases, actually quite robust evidence. Sorafenib was the subject of a randomized controlled clinical trial, which we'll discuss. But notably, none of these therapies are currently approved by the FDA for desmoid tumors because that process hasn't been undertaken for these older agents. Does not mean they don't work, but they don't have that approval. Systemic therapy has a role in treating desmoid tumors, specifically chemo. So this is cytotoxic chemotherapy like the medications that we use to treat cancer. Doxorubicin-based regimens have historically had the best success rates. Those responses are slow. So we typically will treat patients with somewhere between 4 to 6 rounds of chemotherapy, and you will see tumors maybe begin to shrink or stabilize and then continue to shrink for months or years after treatment. Vinblastine and methotrexate is another low-dose chemotherapy combination. It's given weekly in most cases. This is very popular in the pediatric population because the long-term side effects associated with methotrexate and vinblastine are well studied and limited. And so we still see this frequently used as the sort of the initial standard of care treatment for kids. It's also effective in adults. It tends to work very slowly. The combination is not typically that toxic. It's just slow. I think that's the challenge. Tyrosine kinase inhibitors, sorafenib and pazopanib have the best evidence. Sorafenib is the subject of a phase 3 randomized trial, and pazopanib has other prospective studies that are less robust than sorafenib, but are clearly active. Imatinib, which is a really well-tolerated tyrosine kinase inhibitor, and for that reason, we do see some patients come in on it because it's been studied, but not as robustly as these others. And I think the sense is that it probably works less well, if at all, in desmoid tumors. And so we typically in our practice don't use it. That being said, it is still on the list of available agents for the disease, although not with an FDA approval, just expert guidelines. So the sorafenib study, I think, is an important one to talk about. This was published in 2018 in the New England Journal of Medicine. They took a hodgepodge of patients. These are patients that had progressing disease by a little bit, or patients who were just told they couldn't have surgery for whatever reason. It may not have been technically impossible. They just said the surgeon didn't want to operate, or they had symptoms. So these are not all patients that have tumors that are growing, but that's who was included on the study. They were all adults, and they were randomized. So half the patients got sorafenib and half the patients got placebo. And for those patients who progressed, they were allowed to, if they had been getting placebo, they were allowed to cross over to sorafenib. And this is a Kaplan-Meier curve where you can see again that these are the percent of patients that don't have their tumor grow. And for sorafenib, that number was in the range of 90%, and then much lower for placebo, demonstrating that sorafenib is an active therapy in patients with desmoid tumors. But what was really, I think, important in this study, it was the first time that we saw in a study where patients were followed prospectively, meaning that we actually treated them and followed what happened to them, where we saw that, yes, sorafenib, and this is a waterfall plot, so any bars that are going down, each one represents a patient whose tumor shrunk. Any bars that are going up is a patient whose tumor grew. So you can see on sorafenib, many patients had their tumors shrink, comparatively few had their tumors grow. But that's also true for placebo. Sorafenib had a higher number of patients that responded, but placebo for desmoid tumors is not bad. And that's the reason that observation has really become the standard for patients who can tolerate it. You can get away without treating these patients, and they will still have their tumors respond a significant portion of the time. This is the trial that evaluated pazopanib, and they compared it to methotrexate and vinblastine. This was a randomized study, but it didn't have as many patients. It wasn't really meant to make a comparison. That being said, it demonstrated that pazopanib probably works very well. I hesitate to say better just because the study wasn't designed that way, but the group of patients who got pazopanib did better than the patients who got methotrexate and vinblastine in terms of improvement of their symptoms. And that's the same waterfall plot here. So you can see that we don't put them on the same curve because it wasn't designed to compare the two, but the 6-month PFS was longer for pazopanib versus methotrexate. Okay, so side effects related to cytotoxic chemotherapies and tyrosine kinase inhibitors. Cytotoxic chemotherapy is something that many oncology nurses are quite familiar with, but with doxorubicin in particular, you see cytopenias, nausea, vomiting. Vincristine with the methotrexate can cause peripheral neuropathy and constipation. Mouth sores are not infrequent with doxorubicin. Certainly fatigue, liver side effects, cardiac side effects with doxorubicin as well. And those are managed the same way they would be for a patient getting chemotherapy for their sarcoma or for their breast cancer. The tyrosine kinase inhibitors that we use also have on-target and off-target side effects. They have cytopenias. They are milder than the cytopenias that we see in patients getting chemo, but they are still there and sometimes significant. Lower extremity swelling, diarrhea, fatigue, pain. Sorafenib can cause irritation of the skin on the hands and feet. Pazopanib causes loss of pigmentation, so patients see that their hair gets white, they're more sensitive to the sunlight. And so these are not entirely benign therapies, even though they are oral, which does carry some level of convenience. So the new kid on the block, so to speak, is the class of medications called gamma secretase inhibitors. And I think it's an interesting story. These are medications that were initially developed to treat Alzheimer's disease. It was thought that gamma secretase inhibition would inhibit the formation of these plaques that we see in patients with Alzheimer's, but they were not successful. Gamma secretase does a bunch of things, including cleaving this signaling molecule called Notch, which is implicated in many cancers. Although interestingly, prior to these drugs being developed for desmoid tumors, Notch wasn't really on the scene for desmoid tumors that often. There's crosstalk between the beta-catenin pathway that we discussed earlier and Notch. But the way that we found this was that simply that patients, while they were trying to do the initial dose-finding studies of the gamma secretase inhibitors, there happened to be a few desmoid patients that were placed on those studies and they responded. That led to a phase 2 study where more patients responded, which ultimately led to the phase 3 study that we'll be talking about today. So while we think Notch signaling is likely involved in its crosstalk between these pathways, the fact that we're talking about this today for desmoid tumors starts kind of serendipitously. So the DeFi study, which is the phase 3 study, after the phase 1 and phase 2 had already shown signals of response, is a study that took patients with confirmed desmoid tumors, and it's a slightly different population than the sorafenib study I showed you before. All of these patients had to have their tumors growing by at least 20% in the 12 months prior to them going on study. So instead of that hodgepodge of surgery or no surgery or pain, it's all the patients had to be growing. And that selects a much more aggressive population of patients. There were patients both with beta-catenin mutations and FAP on the study. And they were all adults, older than 18 years old. They were randomized to receive nirogacestat, 150 milligrams twice daily, or placebo. And if they progressed, they were unblinded. And if they'd been on placebo, they could get nirogacestat. The key endpoint was progression-free survival. So how long before the tumor grew? And then there were a number of secondary endpoints, including patient-reported outcomes and symptom burden. And we'll chat a little bit about some of those. So this again is the Kaplan-Meier curve. So this is on the y-axis here. You have the probability of tumor progression. And you can see that nirogacestat had fewer patients, or many more patients, I should say, that were progression-free over the course of the study versus placebo. The study also looked at specific subgroups. They wanted to understand, do men do better? Do women do better? Are there any groups of patients where nirogacestat doesn't work better than placebo? And the answer is in all of the groups they looked at, whether it was gender, location of the tumor, the mutation, what prior therapies they had, nirogacestat seemed to do better than placebo. So the objective response rate, the number of patients whose tumors shrunk by 30% or more, was 41% in the nirogacestat arm versus 8% in placebo. So in the sorafenib study, recall that placebo was close to 20%. Here it's only 8% because we've chosen a group of patients whose tumors were growing along the way. The time to response, meaning the time it took for the tumor to shrink by 30%, was 5.6 months for nirogacestat versus 11.1% for patients with placebo. And these are the waterfall plots again. So each line here is a patient, and if it's going down, it's a patient whose tumor shrunk. This line here is at 30%, and you can see more patients had their tumor shrink on nirogacestat than did on placebo. But even here, in these patients who all had tumors that were growing at the time that they went on study, you can see something like half of patients have some shrinkage in their tumors, with 8% of patients having that 30% shrinkage that counts as a response.
Now that we've looked at, the data that was seen on the DeFi trial, they also looked at the quality of life of patients on that trial as well. So if you look at the blue line on these graphs here, it shows that nirogacestat lessened pain intensity for patients, so overall improving pain for them, as well as their total symptom score. So symptoms that patients were reporting improved while being on nirogacestat. As well as the physical functioning impact score also improved while on nirogacestat compared to placebo. Looking at the safety of the trial, so treatment emergent adverse events that were reported at any grade included diarrhea, nausea, fatigue, hypophosphatemia, a maculopapular rash, headache, and stomatitis. We'll go in more about the management and these side effects on later slides. Dose reductions that were due to the adverse events reported included 42% of patients underwent a dose reduction, and up to 20% of patients discontinued due to the events that they experienced. No adverse events led to death while on the nirogacestat. So nirogacestat today is indicated for adult patients with progressing desmoid tumors who require systemic treatment. As discussed on the previous slide, some of the warnings and precautions that we discuss with patients include diarrhea, ovarian toxicity, hepatotoxicity, risk of non-melanoma skin cancer, electrolyte abnormalities, and it is not indicated for women who are pregnant due to embryo-fetal toxicity.
There is an additional gamma secretase inhibitor, which is currently in development, and this is the phase 2/3 Ringside study, which is currently ongoing. So the final results of this study have not yet been reported, but this is very similar in design in terms of the patients who are on the study to patients who are receiving, who are on the DeFi trial. So the initial phase 2 study had slightly looser requirements, with patients having only 10% growth in the last 18 months instead of 20% growth in the last 12 months. or patients with pain. But now for the phase 3 portion, the criteria are essentially identical to nirogacestat. They tested 3 different doses to figure out which dose they were going to bring into the phase 3 and have elected to go with the 1.2 milligrams once a day. And so the only real available data right now are the phase 2 data comparing different doses of varegacestat. There's no placebo-controlled data available yet. That trial is ongoing, and we hope will be reported in the coming year or two. But in that phase 2 study, with the different doses, response rates range from 23 to 50%, depending on the dose, and responses were seen in all subgroups. But like I said, the phase 3 study is ongoing. I think it's too early to say where this is going to fit into the landscape of desmoid tumor treatment, but it's something that we're watching with real interest. In terms of side effects, there's really no way to do a head-to-head comparison of nirogacestat versus ringside. I think it would be very it would be reckless to try to do so. But what I'll say broadly is the side effect profile is quite similar to what we saw in DeFi with diarrhea, nausea, hypophosphatemia, stomatitis, all being known side effects of the gamma secretase inhibitor class, and how it compares is something that we'll have to understand over time.
So looking at a summary of the gamma secretase inhibitors, the DeFi trial demonstrated that nirogacestat induces responses as well as improves pain and quality of life in patients with desmoid tumors. Ovarian dysfunction is a side effect that we'll talk about in the coming slides. Optimal duration of this therapy, or really any therapy for desmoid, is not known. The ongoing ringside trial has demonstrated preliminary evidence of efficacy. So varegacestat versus placebo is still ongoing at this point. So in patients that you'll experience both in your clinics and in the community setting, you might wonder, how do patients and how do practitioners decide, to continue watching with surveillance at this point versus going on treatment? So for a lot of our patients who elect not to start treatment at this time, they often present asymptomatic with a stable tumor. And for those patients, we recommend active surveillance. So that would include regular imaging and follow-up, usually at a 3-month interval. If the tumor is shrinking or spontaneously regressing, we would also recommend continuing observation in those states as well. For FAP-associated tumors that are also asymptomatic, we would recommend observation and only start treatment when symptoms present bothering the patient or progression on imaging. For a progressive tumor that is growing on imaging, some patients and practitioners will choose to still observe for 3, 6, and 9 months to see if it continues to progress at that time, while other patients can have a shared decision-making conversation with their practitioner if they wish to go on systemic therapy, including nirogacestat, sorafenib, or pazopanib. Surgery can be considered for those select abdominal wall cases, as well as radiation or cryoablation could be discussed as well. Patients who are experiencing significant pain, symptoms, or threatening critical structures or organs, depending on location in the body, we would recommend systemic therapy, as well as NSAIDs for symptom control and possible local therapies such as ablation if feasible. Abdominal wall desmoids that are not responsive to observation could be referred for resectable surgery. And then some patients that cannot tolerate systemic therapy, that would be case dependent in a discussion with the practitioner and the patient for what they're hoping to gain from their quality of life. So looking at the nursing role again in desmoid tumor treatment, as we know, nurses are trusted sources for patient education. There are desmoid support groups out there for patients, as well as the information that we have from nirogacestat. We've learned a lot from that trial and the ongoing trials to provide education on treatment expectations, helping patients align goals of care, and counseling on therapy adherence for best possible outcomes. Next, we'll look at targeted therapies and adverse events. So looking back here at Tina, systemic therapy was recommended for Tina Z. She enters a trial of a gamma secretase inhibitor and reports approximately 8 bowel movements a day and irregular menstrual cycles. How would you manage her side effects? So looking at serious adverse effects of nirogacestat, Diarrhea persisting for greater than or equal to 3 days despite maximal medical therapy. In my own practice, we often define diarrhea that's persisting despite maximal medical therapy as greater than 6 stools a day and affecting, their day-to-day activities. We often recommend starting with Imodium at the maximum dose, as well as we can add Lamotrigine for these patients as well. Lab monitoring on nirogacestat includes comprehensive metabolic panels to check if ALT and AST is increased. At that time, depending on severity of increase, we could either hold therapy or if a dose reduction is warranted at that time. We can also see hypophosphatemia that's persisting despite maximal replacement therapy, hypokalemia as well despite replacement therapy, ovarian dysfunction, which we'll discuss on the next slide, and then management and approaches for managing these adverse effects are similar to those used for other agents that you'll be familiar with. And dose modification is always an option. For nirogacestat, it's you typically start patients at 150 milligrams BID, and you can go down to 150 from there as well. Frequency and resolution of ovarian dysfunction seen with patients on nirogacestat. So among women of childbearing potential, ovarian dysfunction was observed in up to 75% and 0% receiving placebo. The median time to onset of ovarian dysfunction was 8.9 weeks. The median duration of ovarian dysfunction ranged to 21.3 weeks. In patients who discontinued nirogacestat, ovarian function did appear to recover. So as we've kind of discussed on previous slides, the nurse's role in managing gamma secretase adverse events will be focused on the treatment and management of diarrhea, nausea, rash, fatigue, stomatitis, ovarian toxicity, and increased AST and ALT. The less common serious adverse events can include hepatotoxicity, electrolyte abnormalities, and non-melanoma skin cancers. You do want to educate your female patients on the potential for ovarian toxicity, including that the long-term effects on fertility are unknown.
So in summary, and I'm excited to get to some of the questions. I want to acknowledge that folks have left some thoughtful questions in the question box there, and I'm looking forward to getting to those. But desmoid tumors are generally speaking associated with low mortality. We do see some patients who die from desmoid tumors in bad locations or with particularly aggressive disease, but that's the exception and not the rule. Observation is recommended in nearly all patients because they will experience spontaneous remission in 20% or more if you wait long enough. Surgical resection isn't the preferred treatment. Due to high recurrence rates, yes, and it's 20, 30, 40%, but more than that, it's the functional consequences of surgery. If someone has a desmoid tumor in their arm that limits mobility, resecting their biceps muscle doesn't improve that mobility. And so now that we understand that these tumors don't just keep growing no matter what you do, we've started to get away from surgery as an option and look at radiation, cryoablation, and very frequently systemic therapies because you can improve function. And I think that's the key for most patients with this disease. There's multiple options for systemic therapy, including targeted agents. The level of evidence is highest for nirogacestat and sorafenib. Nirogacestat has the FDA approval based on the DeFi study, which we discussed. And so the class of agents is exciting. I mean, I think this is something that we're seeing used very frequently as frontline therapy for patients with desmoid tumors. In general, I would say that because we have radiation and cryoablation, rarely surgery, and medications as an option, we do our very best to have as many of our patients seen by our multidisciplinary team. We have radiation oncologists, interventional radiologists do cryoablation, and surgeons weigh in routinely on the care of our patients. And it's part of the reason that when possible, seeking care at a specialty center, at least to help set the plan, is helpful. So we're going to pivot to Christina one last time to close us out. And then I think before we end the session, we'll try to make it through as many of the questions as we can.
I love my care team. I have shouted praise to them from the mountaintops. They're the ones that initially diagnosed me back in 2018. Initially, it was a thoracic surgeon because one of my many misdiagnoses was a hematoma from surgery. That thoracic surgeon is the one who said, "Hey, I see sarcomas all the time. That's what I think we're dealing with here," and referred me to his friend, the oncologist, among another treatment team for my initial kind of assessment from that first day. I work primarily with the oncologist and the nurse practitioner in the sarcoma program, as well as, of course, the unsung heroes, the care team of the hospital administrators who are doing all the paperwork that I need, who are making sure that my scheduling lines up with my scans, etc. My oncologist has really been a partner in my healthcare, allowing me to have veto power when I need it. Initially, my mental health wasn't being considered as the other part of this picture. Thankfully, there was a social work intern at the program who referred me to a therapist and got me taken care of and lined up for a better path with mental health. I will say that I see the nurse practitioner as much as I see the oncologist. They both are very familiar with me and my life. And I think where they really knock it out of the park is what you mentioned, working as a team. They communicate with each other very clearly. I've never had them drop the ball on anything. They pull out their cell phone to text the other person right away. And I greatly appreciate that.
I think before we get to our SMART goals to end out the session, perhaps we should take a few minutes and answer some of the questions. And so trying to bucket some of these in themes, I think talking a little bit about nirogacestat and women of childbearing potential, I think that's a question. So let me start with a little bit, and Nicole, please feel free to jump in as you like. So, I don't know that we fully understand what estrogen does to desmoid tumors. We completely understand that young women get these tumors more frequently than other groups of patients, and it may be that estrogen plays a role in that. There's been an observation historically that we see more desmoids, or we see desmoids maybe even rapidly growing in patients who are pregnant. But how much of that is because the high estrogen state is feeding the pregnancy versus just young women or the patients who get desmoids? It's not totally clear, and there's not a great way to tease that out. We also see sometimes in patients after they deliver, or if they're on birth control after they stop it, the tumor shrinks, but the tumors can also just shrink on their own. And so it's been very difficult to understand what it means to sort of to be on hormonal therapy and sort of how estrogen interacts with these tumors. With respect to nirogacestat in fertility, we don't know that full picture yet. I think we know that the patients on the study who stopped nirogacestat, they had their periods return essentially to normal. I think that's encouraging in terms of potentially fertility also returning to normal, but those patients haven't been followed for 15 years to see if their childbearing is as successful as patients who haven't had the medicine. So I can't tell a young woman there's no effect because we just don't know yet. Now, SpringWorks and the company that made nirogacestat has been obligated to do some of these studies as part of the approval, and so there will be more information over time. Right now, I typically have any patient who's going to be started on a desmoid on nirogacestat, or most of these desmoid therapies, frankly, visit with a fertility counselor just to sort of get an explanation of their options. And I have had some that choose to do egg retrieval, for example. Desmoid tumors, it's rarely an emergency to start treatment, and you often have time to at least explore those things before you start a patient on treatment. Nicole, is there anything that you would add to that?
No, I think that's great. The fertility preservation, we have discussed with patients as well, just since there truly are so many unknowns.
Yeah. Another couple of questions I'm just going to tick off here. So I think I talked about estrogen and DTs. We will still often stop exogenous estrogen in patients who have desmoid tumors. Whether or not that's what causes their tumor to stabilize or shrink, I can't tell you. We don't know. Would nirogacestat benefit DTs with APC in the tumor? The answer appears to be yes. So that was one of the subgroups that they looked at in the DeFi study, and APC patients seem to benefit just as well as everyone else on the study. Most patients with familial adenomatous polyposis, by the time they present with a desmoid tumor, you already know that they have it because most of them have a history of colectomy or a heavy history of colon cancer in the family, although not always. And for young patients, we'll often at least make sure that that's been explored. You can test for APC. You can test for, most often we test for beta-catenin in the tumor and identify that mutation. It's not necessary though, and the diagnosis can be made without confirming the genotype of the tumor. Let's see. So what's the recommendation for surgical resection of abdominal wall desmoid tumors and concern for recurrence? So this is actually still a hot topic. I think that there are groups out there that have demonstrated that their local control rates with surgery for tumors that are in the abdominal wall, not inside the belly, but in the wall, may be favorable and will offer surgery. Candidly, by and large, at my institution, we do not do that. We offer systemic therapy or cryoablation or radiation for these patients. Primarily because when you're talking about removing a desmoid tumor from the abdominal wall, it's a full thickness resection of the abdominal wall, typically with the flap and mesh to close. And so that doesn't improve function, right? And so generally speaking, we have not done that, but in some older guidelines, abdominal wall desmoids are considered a place where surgery might be thought about. I would say that should be considered in case-by-case situations. Are there any questions here, Nicole, that you wanted to jump in on?
Yeah, I can jump in on a few here. Are managing AEs such as fatigue, GI, and skin with gamma secretase inhibitors different from the usual management of AEs? No, I would say, we're not doing anything different. Just really managing the symptoms for the patient. For nausea, using Zofran, using Compazine. For diarrhea, using that Imodium and Lamodal. And also the team that I work with, we're not opposed to doing a hold for a week and rechecking in with that patient next week to make sure that symptoms are manageable for them or have somewhat improved prior to restarting or considering a dose reduction at that time. For what patient-reported symptoms are most clinically significant, I would say in my patients, pain, and then sometimes physical appearance. I have a few patients with desmoids either on the back or the neck that significantly impacts their physical ability to move around. I also have one patient, her desmoid is deeply embedded in her arm. So it doesn't bother her on a day-to-day, with certain movements. She complains of different sensations and all of that. But she's been managed on sorafenib now for many years. For what organizations are available to provide mental health support. At the institution that I'm at, we do have a psychologist team available to our medical oncology cancer group. So even though desmoids are not classified as a cancer, they are still able to be seen by our psychology group. I would also recommend the desmoid patients that you could be caring for, that there's Facebook support groups and all of that I know are beneficial for patients as well.
All right. I think in order to sort of be conscious of time, we're going to close out. So just to leave you with some SMART goals, we're trying to improve familiarity with desmoid tumors. We want folks to know that these are out there and to sort of just be aware that not all soft tissue swellings are benign. And between desmoid tumors and the other malignant conditions that Nicole and I care for, be aware that, ultimately you want to go into these things with some level of skepticism and make sure you know what you're dealing with. We want to make sure that people know what's out there for treatment, right? And that there are guidelines published by the NCCN and other groups that explain how best to treat these tumors. And that, we want to make sure that people are conscious of exploring adverse events and making sure that patients know what they're getting into as they dive into treatment. Okay, so our last message from Christina.
I really, most importantly, hope that my thank you makes it to them, because that's the biggest thing. Their nurses are often overlooked, and they have been the ones that have gotten me through the hardest time. I have my favorite nurse who brought me my warm blankets when I was getting infusions. The nurse that remembers the name of my dog. They are the magic that keep and have kept me grounded throughout my treatment.
I will add my thanks to Christina's. I would not be able to care for my patients as successfully as we are without the support of both my clinical nurses and APRNs who do a tremendous amount to support our patients through the journey. So I'll add my own thanks to that. I want to thank all of you and Nicole for spending the evening with us today. And thank you for everything that you do to care for the patients.